Very good evening, friends. It's really a great pleasure to welcome all of you. Okay, guys, I'm here for a reason. It's an interesting story of a journey from analog dentistry to the digital dentistry. Okay, anyway, the best thing ever happened to me, I would say, is this is an interesting story from an analog dentistry to a digital dentistry. The best thing ever happened to me was I graduated during the analog dentistry. And the second best thing, what I did was I did not stay loyal to it and shifted towards digital. Now, today's topic seems to be very popular. This helps us become successful in our practices, and I'm really honored and thankful to Dr. Buzin and DDF for giving me an opportunity to share some of my views. I'm practicing in Bangalore, and I have an integrated digital practice here. Now, when it comes to a patient, what could be the better perspective for our patients to receive from us? Now, as doctors, we need to generate health, self-esteem, and confidence. Our patients should smile with confidence, irrespective of the teeth being symmetrical or not. A healthy mouth, but not a perfect smile, doesn't need to be changed if the patient is confident. So, getting into the current era of digital revolution, now the question is, how does this help us? So let's see, how do we set up a successful office, and digital smile design will definitely help us do that. Now, having said that, most of my practice has always been analog till I shifted towards digital. And undoubtedly, after the shift technology, I understood that technology is a way to do better dentistry. Now, that doesn't mean that people without digital aren't doing better. I know clinicians who are very loyal to analog dentistry and are doing extremely well. But how does the shift to technology help us? Technology helps us to be more predictable, very precise, profitable, and more importantly, a better decision maker. Now that all the digital strategies are created, how do we sell this? As somebody has to pay for it, right? So what we do is we expose our patients to the digital workflow. That's a very, very important thing. Get them involved in this, because you see, everyone loves technology. I do. I love technology. So does our patients as well. Now, if the same technology is personalized to that particular patient, then there is a good connection between the dentist and the patient. Now, because of this, they start valuing our treatment much better, and that creates a better education and motivation to the patient. Uh, Now let's remember, no matter how good dentists we are and how good dentist one can be, the end of the day, the patient has to say yes for the treatment. Now, when we have a personalized digital plan for the patient, that is how they will decide to invest on the smile. So we need to connect to our patients more concretely. Now, this concept of DSD was coined by Dr. Coachman as emotional dentistry. So now DSD is more of an emotional dentistry. It is a guided dentistry where the final outcomes are already seen and our treatments are much more predictable. Now, let me warn all my colleagues here. The digital dentistry is an irreversible process. From the moment one takes the first step into the digital universe, it is impossible to turn back. And trust me, you will love it. Now, that is about the digital revolution. Now, the burning question here usually asked is, does digital dentistry replace our technicians? Absolutely no. The hand skills, our technicians' hand skills was and will always be indispensable. It can only get better. Remember, even before we got into digital, years before or even decades before, our technicians are been doing digital dentistry even before we started. By us upgrading to digital, the marriage between the dentist and the technician gets more stronger. Now, digital is not here to deny the analog dentistry, or digital is not here to question what our mentors did in the past. Digital is here to facilitate us to do better. Definitely, digital is a much more predictable way of doing dentistry. But having said that, digitals are not the way to learn clinical skills. That's always has been and will be the analog way which makes us a better clinician. In the learning curve, it's better to take advantage of the digital. Uh, Now, I have also noticed few skilled analog dentists. As soon as they start doing digital, they will save time, they will improve their production, they'll be able to see more patients. And let's not forget, they are the analog dentists for a long time. They will still use their skills to fine tune what is done on the computer. Now, the question is why digital? Now, in terms of patients, the communication between the patient and the operator gets much stronger and much emotional. Patients start valuing our work much better because that is the one area which we are lacking here. Between the team, the communications get better and there's a collective intelligence. Everybody wants to pitch in something or the other. Treatment planning is always on the top notch when it comes to digital. Very well standardized treatment with a digital workflow, and the quality control is always maintained at very high. Now, in terms of business perspective, it markets us better and it creates a much, much better brand identity. Coming to the smile design. Now, what is a smile? Let's see like how we can do a smile design to transform smiles for better. Now, here we need to consider the pink aesthetics as well as the white aesthetics. The combination or the mixture of pink and white, when we can evaluate it and we bring about certain changes, that gives a positive influence on all the overall aesthetics of the face. So it's always a mixture of white and pink. Now, we know this, there is facial analysis, dentolabel analysis, and tooth analysis. Now, these parameters integrate teeth, gingiva, lip, and face. We definitely need to follow these parameters, but apart from that, there are also subjective artistic parameters for that particular patient. See, other various parameters, what we can list out is could be lip dynamics, lip support, the smile curve, the dentogingival midline integration, buccal corridors, dentogingival parameters. Now, all these parameters are definitely not new for us. It's always been there, and we have been trying to put all these parameters when we are doing complete dentures. So these parameters have always been there. Now, a starting point from whenever we do a smile design, the facial midline is often a starting point. The facial midline does not always match the dental midline. I repeat this, facial midline does not always match the dental midline. And it is very important to understand that this is not an aesthetic issue. The issue is when the dental midline is canted. So the important thing is to have a parallel dental midline to the facial midline. Glabella, philtrum, soft tissue cogonium are the reference points for the dental midline. Philtrum being the strongest visual reference for us to determine our smile design. As mentioned earlier, shift is not a problem. Cant is what we want to avoid. We really don't have to complicate the treatments to fix the dental midline. Now, if we see some of the literatures here, Kokik in 2006 has clearly said that the shift of a facial midline from a dental midline by 4 millimeters is not an aesthetic disaster as long as they are parallel. The next parameter what we see here is the horizontal aesthetic and the horizontal aesthetic planes, which is the interpupillary plane as well as the commissural plane. Now, the interpupillary and the commissural plane are the two strong visual references which we want to integrate our smiles to this line. In two-thirds of the population, there is a very beautiful integration between the interpupillary line and the commissural line. In one-third of the population, there is no integration at all. So we need to find an average position between the interpupillary and the commissural line to design a pleasant smile. Then coming to the incisal edge, we need to understand very clearly here that the genesis of smile design, the science of smile design is only with two teeth, that is the two central incisors. If we can nail the position of the two central incisors, as per the lip dynamics, as per the phonetics, then the rest of the teeth, the laterals, canines, and premolars, they all follow only the artistic rule. So the genesis of the smile design is only two teeth, which are the dominant tooth of the mouth, which is the two central incisors. Now, the next parameter we can consider is to determine our smile curve. Now, smile curve is a multifactorial decision. We need to understand the lip dynamics and the whole face to make the decision. If we want to make the teeth longer or wider, or even buccal corridors narrower or broader, we need to analyze the teeth in resting position as well as smiling position. That means static as well as dynamic. And we need to combine this with the gender and the age of the patient. In smile line, this basically exposes the anterior teeth during smiling. Now, there are, as per the classification, there is a low smile line which exposes 75% of the teeth, an average smile line which exposes 75 to 100% of the teeth, and a portion of the interdental papilla, and a high smile which exposes complete teeth as well as lot of gingiva. So a pleasing smile is that which exposes complete maxillary teeth and a portion of the gingiva. An excessive gingival display of more than 3 millimeters is usually considered as unattractive by some of the patients. So we cannot say which is ideal. Is average ideal, or if it is low smile line ideal? So let's try to see some of the studies here. In 1994, Tian had made a study, and he said that a very small percentage of the people are falling in a high smile line, and a major percentage are falling in a medium smile line, which means very clearly the importance is given only for white aesthetics. Pink are not considered, right? A very small population. Then further going on to the studies in 2014, Nord concluded that it is not 10.5%, but 38% of the population is falling in the high smile cases, which means there should be a consideration which should be given to the pink aesthetics as well. But still, a lot of population was falling in the medium smile cases. Now, this was all outruled in 2016 by Dr. Coachman and Mann, where they concluded that more than 60% of the patients are falling in the high smile line cases, now complicating the treatment from white aesthetics as well as pink aesthetics. So why did these numbers change? The numbers were changed because all the previous studies were done under pictures. When a patient is asked to smile, they show 30% less smile. So the new studies of 2016, which was conducted by Dr. Coachman and Mann, was all done under videos, and that was a surprise, which said that more than 60% are falling in the high smile line cases. That is where now the treatments gets more complicated because it is white as well as pink. The conclusion of all these studies is most of the patients are having high lip line. Actually, we are just failing to capture the moment where they show maximum soft tissue display. Okay, coming to the next parameter, which is the smile window. Smile design does not mean only for the upper six teeth. Now, rather, when the patient smiles, all the teeth in the aesthetic zone has to be considered. Lip movement, when smiling, generally exposes the anterior teeth along with the premolars as well as the molars. Now, since we are working on an Asian population, 57% of the smile width are till the second molars, and roughly 20% are showing the smile width till the molars. So the aesthetic zone or the smile zone is still where the last teeth is seen. That would be the consideration for the treatment or for doing a smile designing on an ideal situation. Now, in 1970, Pound said that when the patient says E, this is when the patient says E is to expose the smile window, 80% of the smile window has to be filled by the upper teeth, and 20% has to be filled by the lower teeth. This was way back in 1970. Pound had already told about this. Um, okay, so if we see when we talk about a balanced face, now these are all the lines which are trying to the vertical lines and horizontal lines and the smile lines which are trying to make a strict geometry for the face. But all these lines doesn't mean we have to exactly fit everything in there. They are just the guidelines. The art will dictate these lines. The creativity and the artistry can make things slightly asymmetrical, but it will still look very, very beautiful. Now, coming to the next parameter of dentolabel analysis. Now, what is dentolabel analysis? The most common phonetic analysis, what we ask the patient to do here is to ask the patient to say M and relax the lip. And then when they say M and relax, we gently part the lower lip and see what is the amount of gingival display we have. Do we have a larger gingival display? Do we have a smaller gingival display, or absolutely an absence of gingival display? So what we know is that women show more teeth at rest than men. This is a very important information to be taken into consideration. Younger people will show more, older people will show less teeth. So when older people come to us and ask for a youthful smile, all we need to do is increase the display. So um, if you see here in the first picture, there is a lot of display, and the second one, there's less display. So we usually consider in an ideal parameters, 3 to 4 millimeters of display for a younger lady is good, and 2 to 3 millimeters of display for a younger male should be okay. Now coming to where does our incisal edge has to rest? Now, a fundamental aspect of an aesthetic diagnosis is the identification of the position of the incisal edge. This is very important. The incisal plane, when we observe from the front, should have a convex curve that follows the lower lip, where the laterals are slightly higher in position considered to the centrals. Now, when it goes slightly higher, that means our canines also will go slightly higher. This will give a radiating symmetry to the smile. A radiating symmetry is always a youthful smile, and a horizontal symmetry where the laterals, the central are at the same plane, laterals are at the same plane, canines are at the same plane, all the teeth are in the same plane. That creates an horizontal symmetry, which is actually describing an aging appearance. Now, in the position as per the classification, we have the lower lip not contacting the upper incisal edges, or we can have the lower lip gently contacting the upper incisal edges, or lower lip partially cupping the incisal edges, right? So from an aesthetic standpoint, contacting is considered to be particularly pleasing. Now, this is an example of an horizontal symmetry. If you can see here, all the teeth are in the same plane. And this is an example of a radiating symmetry where you can see the centrals are lower, laterals are slightly higher. And furthermore, the artistry goes with raising up the canines and the premolars. That's the radiating symmetry for the youthful young lady. Now, coming to the next parameter of central length width proportion. We know from articles that width to length ratio should be 75 to 80%. That means if the central is 10 millimeters long, then the width should be 7.5 millimeters or 8 millimeters. So what do we understand from this is an ideal is 80%. We can even have a range of 75 to 80%. We can play around these values. If we want to make the tooth look longer, all we have to do is reduce the width. If we want to make the tooth look broader, all we have to make the tooth broader, the width broader. So, but ideally is considered as 80%, or the ratio is range is between 75 to 80%. This was already told in 2000 article. Now, few articles are talking about the measurements of the teeth. Now, Nelson in 2009 has clearly said the central incisors ranges between 10.4 to 11.2 millimeters. Now, this is to create a nice central. So it is considered as the central ideally should be between 10.4 to 11.2 millimeters. The next parameter is the papilla curve. Now, Stephen Chu in 2009 has clearly said a beautiful papilla is half the length of the centrals. This is very important when we place implants in the anterior zone because beautiful papilla have much more volume and length than we could imagine. If the two centrals are very placed very close to each other, and then we don't have enough position for the papilla to grow there, and then the papilla will appear thin and very elongated. If the roots of the tooth are much away, then the papilla will be appearing rather flat and unattractive gap between the two teeth. Now, Stephen Chu in 2012 came up with an article saying that the interdental papilla display, when the patient smiles, an interdental papilla display is seen in 91% of the cases. That's a huge number, what he has said, which means soft tissues has to be considered when we're doing the smile design. We cannot stick to the whites alone. It is white and pink always. And in 91% of cases, as per the study of Stephen Chu in 2012. The next parameter is 50-40-30 ratio. What is 50-30 for 50-40-30 ratio? Now, if you see this is how we are planning the contact points, contact areas rather. The contact area between the two centrals should be 50% of the length of the centrals. That is, the central length is 10 millimeters. The contact between the two centrals should ideally be 5 millimeters. And the contact between the central and the lateral should be 40% of the length of the central incisors. Right? Was central incisor was 10. Now the contact between the central and the lateral becomes 4 millimeters. Now a contact between the central and the, a contact between the lateral and the canine should be 30% of the length of the central incisors, which means that if the central incisor length is 10 millimeters, the contact between the lateral and the canine should be 3 millimeters. So this is how we follow the contact. Now, by doing this, what happens is you see the contact between the two centrals are very low. The contact between the central and the lateral are slightly rising up, and contact between the lateral and the canine are raising up further. Now, this itself is creating a smile curve in the contacts. Not only this, it is from the horizontal symmetry, it is creating a radiating symmetry, giving a much pleasing smile. But we don't have to strictly stick to 50-40-30 rule. We can even play around with 40-30-20 rule as well, as per your artistic judgment for that particular patient. Now, coming to the gingival, the gingival margin of the tip of the upper gingiva should be in the same plane as that of the canine. That is considered as aesthetically very, very pleasant, and the lateral should be slightly lower. That's a dream patient for us to get, that's laterally slightly lower. So this would be considered as an ideal aesthetics. Now, let's be very practical here, that we might not get all the cases like this. Even if the lateral go slightly more apical and reach the line connecting the central and the canine, it is still not an aesthetic disaster. Aesthetic disaster is when the lateral goes much more apical to the line connecting central and the canine. Next comes is the zenith. Zenith is the most apical point on the gingival outline. In the maxillary teeth, it's usually or normally located distal to the long axis of the tooth. Now, very ideal and very pleasant if we happen to keep this, if we can maintain this in all of the teeth. It doesn't matter if the zenith moves to the long axis, but it becomes aesthetically unpleasant. And the patient, if the patient has a high smile line, if the zenith moves mesial to the long axis, then that becomes an aesthetic disaster. So in a nutshell, when we do a smile designing, it's easier to do a smile designing, always easier to do a smile designing on an edentulous jaw, because we know where we can place each element. Now, it's easier, we can make things easier by trying to visualize it is an edentulous mouth. And the first and foremost thing is we place the midline, facial midline for the we place the facial midline, and beyond it, and then we also evaluate where the incisal edges should fall in relation to the lower lip. So then we mark where the incisal edges has to rest. So we have already got two boundaries. One is the facial midline. Second is where the incisal edges has to rest. Now we'll put a third boundary to this. We will try to decide where our gingiva has to form. How do we plan the pink? Now we have got all three boundaries. Now it's a bit easier because the most beyond this, the most dominant tooth in the mouth should be designed first. That is our central incisors. So once we design this central incisor, we make a replica on the other side so that there is a good balance of the proportion. And dominance is created with good balance on both the sides. Then, so as we mentioned earlier, the genesis of smile design is only in the two central incisors, which is dictated by the lip dynamics, phonetic analysis, and then we can nail the incisors in the right position. And from here, we just walk backwards to create the cute laterals. Beyond this, we walk further backwards in creating the monsters, keeping in mind the harmony we need to create and maintain patient's personality. And finally, complete the smile design. And well, you see, it's that simple. Now, careful evaluation of the artistic and scientific parameters will only allow us to improve the quality of work to create restorations that is not only integrated to the oral cavity, but also in relation to the patient's face. That makes us better designers. Of course, that designing would be ideal, which will not be practical for all the patients because we cannot strictly stick to this. We need to show slight deflection from ideal so that the designed smile suits the individual's personality. That has to be kept in mind. Now, it doesn't matter how good dentists we are till the patients will say yes for the treatment. The biggest problem always has been is the acceptance of the patients for our treatment plan, be it orthodontics, prosthodontics, implant aesthetics. Patients are usually time concerned or money concerned. The reason being is that they don't put the dental treatment as their highest priority. But as dentists, we want our patients to value our work. So that is when Dr. Coachman came up with the concept of test drive appliance. What is a test drive? That means, if you want to buy a vehicle, we'll go for a test drive. We like it, we'll make a decision. So why not put the similar concept in dentistry, digital dentistry as well? So he came up with an appliance called as test drive where the patients try it before they buy it, right? Now we'll see what is a test drive as we go into the further slides. So when we are doing a smile designing, first we mark the facial midline, and then we'll mark the interpupillary line. Interpupillary line is nothing but the line which is parallel to the commissural line, or also it is for the anterior aesthetic plane. So these two lines are then looked into the oral cavity. That is, we zoom into the oral cavity from here. Then upper border of the lower lip. Upper border of the lower lip generally tells us the smile curve. So we draw a smile curve and take it onto the edge of the incisors. And in the DSD workflow, we have this special rulers. These can be customized for each patient. I know I'm getting a little bit technical over here, but try to understand. We do the facial analysis, we do the facial midline, we do the interpupillary line. Interpupillary line is nothing but parallel to the commissural line. It becomes the anterior aesthetic plane, right? So that decides if there is a cant in the occlusion or not. Upper border of the lower lip generally dictates the smile curve. So we draw the smile curve and try to place it onto the edges of the teeth. But then that doesn't decide that edges of the teeth has to stay there, which is decided clinically by the phonetic analysis. Now, beyond this, we try to place the golden proportion. Now, golden proportion where we consider the central incisor length to width, which is 80% or 75%, right? So we place the golden proportion, and then we start marking where the curves of the teeth or where the teeth outlines has to come. Beyond this, we place the templates, which is in the DSD workflow. Once the templates are placed, and then those templates are taken to the lip, and the lip morphing is completed. Once the lip morphing is completed, further it is now placed onto the tooth, onto the face. Now this is a facially driven, is a visually driven uh, digital smile design. Okay. Now, in a nutshell, this is how we do a smile design, and we show it digitally to the patient. Now, if I have to elaborate on this, how many appointments are needed and how much time do we need to do all this, right? Now, appointment one, when the patient comes to us, we take patient's photographs, then we make the patient's impressions, and we discharge the patient. Once we discharge the patients, behind the scenes, digital dentistry happens. And then when the patient comes for the second appointment, pre-videograph is taken, post-videograph is taken, then we compile this and we present it to the patient. I'll show you this whole case, right? So the time span, what we need for a very conventional DSD is 3 to 4 days, depending upon how fast your technician can deliver the job. So appointment number one, photographs of the patient is taken. Keep in mind, the smile has to be with slightly parted teeth. Now, this is the DSD workflow. There are no softwares involved in this. This is a very simple way of doing it through PowerPoints, right? So facial midline is drawn first, and which is then drawn with and then interpupillary line is drawn. This interpupillary line is nothing but which is an anterior aesthetic plane. It's parallel to the anterior aesthetic plane. Now we draw the smile line, and we also correlate clinically the phonetic analysis and the lip dynamics. Okay. Let me repeat. There are no softwares here. The whole workflow is happening in a PowerPoint format. Then we crop into the macro aesthetics, and from here we get the digital ruler, and we try to customize this digital ruler for that particular patient. So we try to see the length of the tooth, the width of the tooth, if the tooth has to be made longer, if the tooth has to be made shorter, if the tooth length has to be played around from the incisal area or from the cervical area. So we decide all that with the clinical. Right. So we do that. Then, yeah, okay. I think somebody's mic is on. All right. So beyond this, once we have done this, we place the golden proportion. Once the golden proportion is been put, then as per the Visagism concept, which is given by Dr. Coachman, shape and size of the teeth is decided, and outlines of the shape and size of the teeth is done. And in this particular patient, we had to make the incisal edges slightly longer because she has a vertical loss, right? And then vertical loss she had, and also she was demonstrating more of a horizontal symmetry. So we want to convert this into a radiating symmetry. So from here, we place the templates and we complete the smile design, and then we place this onto the patient's face. And now this becomes a facially driven DSD. Fine. All this is perfectly fine. If the patient is motivated or educated to go ahead with the treatment, she goes. Now, let me make this very, very clear. Digital smile design does not do any treatments. Digital smile design is a greatest motivational tool for the patients to say yes for the treatment. All right. Now, from beyond this, now there will be some patients who would want to really see the changes what we can do in their mouth. Okay, this is what we had previously mentioned as a test drive appliance. Now, how do we do a test drive appliance? So we take when the patient has come in the first appointment, we have already taken the picture of the patient. Now we take the impression of the patient as well. Now this impression is poured and then it is sent to the dental lab. When it goes to the dental lab, we would have done in the digital workflow in the PowerPoint format, we would have done the DSD protocols, and we asked the technician to do a lab mock-up, which is a DSD driven mock-up. He exactly knows, we would exactly, because there is a digital ruler which says precisely how much of length of the tooth has to be increased or decreased, right? So, and that information will be given to the technician. And this is the mock-up which the technician does right now is an absolutely DSD driven mock-up, right? So he does the wax mock-up and this work comes back to us. So once now this is the DSD driven mock-up. Once the work has come back to us, we will start preparing the index. So we prepare the index with the putty, and then we shape the index very well. And now the index is ready for the transfer. Now we recall the patient for the second appointment. When the patient comes in for the second appointment, before we put the patient on the chair, we take a 10 to 12 seconds video of the patient, which is before the test drive, right? Before the test drive. Once the pre-videograph before the test drive is taken, now the patient comes to the chair, and then we have the index which is been made ready. The index is loaded with the resin and carried on to the patient's mouth. So once this is done, the index is retrieved. So we have temporaries which has been fabricated, which has been mocked up by the technician, and quickly the picture is taken and for a very brief moment showed to the patient. And after this, we take a videography of another 10 to 12 seconds after the test drive. So we have taken a video of 10 to 12 seconds before the test drive. Then we do a test drive. Then we take a video of after the test drive, right? Now and then we compile both of these videos. We show this video to the patient, the before the test drive and after the test drive. Now, this is where the patient will, emotionally get connected to you. And also this is how they decide to invest on their smile. Now, so this is a very conventional way of doing digital smile design. Very simple, here tools here. All we need is any computer which has a PowerPoint. And then we get trained in how to do this and a good lab support for this. All right, no softwares. So this is how DSD has begun. And beyond this, Dr. Coachman, so it started with the photography, which is a digital drive alone. Then it came into the videography with the test drive. Okay, so that's how it got better. And then Christian Coachman decided and opened and created a DSD app, which is still available in the Play Store and the Apple. DSD app is now currently available where if you have a patient, you just take a picture of the patient and upload it on the app. The moment you upload it in the app, it goes to the lab in Brazil and they do the design and send it back to you. But of course, it comes with a price tag, right? Now, so that also works if you're ready to invest on this. Now, another way of slightly setting the bar higher, where you get the patient's emotional engagement much stronger, is again by doing a DSD with exocad softwares. Now, exocad software is some of the softwares which our dental technicians have been using for years or even been using for decades, right? So getting trained in exocad would be one way to going forward, because it not only motivates the patient, it even plans the treatment. So what we do in the exocad, it is nothing different compared to what the conventional way, because the principles of smile design, what we have decided, stays the way it is. So the step one here is we take a digital scan and we get an STL file. So when the patient comes for the first time, picture of the patient's picture is taken, JPEG, and patient's STL is taken, the scan is done. Once these two are done, we put the JPEG as well as the STL in exocad software. Once we put it in the software, now this is how we put the STL file here, and we put the patient's JPEG file here. To do a smile design in exocad on a very seasoned hands, it will take around 30 to 45 minutes, right? So now the designing in the exocad software starts. Here, okay. So the incisors are being marked, the commissurals are marked, smile width is marked, and then interpupillary lines are marked, facial midline is marked, dental midline is marked, canting is being noticed, golden proportion is also marked, shape of the teeth are thin. The library of the exocad is very, very vast. We can take a lot of different sizes and shapes of the teeth. Now, the teeth are positioned very well. Precise positioning can be done. If you feel the teeth are more bulky, it can be reduced. If you want to fill up the buccal corridors, we can do that. A small touches with digital carving is done. And we can even change the shape, the shades of the teeth and see which matches on the tooth. So this is how we do it in exocad. So this itself is enough for the patients to get motivated. Now, I would really say one more point, important, very important point here. When you do these kind of exocad digital workflow, make sure that we have to show this to the patient, because in the analog dentistry, what was happening is there was a suspense of what is been happening behind the scenes. Now, let us open up the suspense, because patients want to know what is the amount of work been going on. We want to show them the kind of work what we are doing behind the scenes. So these exocad works of digital smile design, what we are doing, make sure that we show it to the patient. The digital workflow has to be shown. That gives us a better connect with the patient, and they start valuing our work. So once now we have smile design done on an exocad. Now you can see all these layers which is done in an exocad. Now what do we do next? Now we start 3D printing this. So we 3D print this DSD mock, digitally mocked wax ups. So now we have a 3D printed model where the DSD has been done in an exocad software. So now we got the 3D printed model here. Now, again, the same steps of what we have done in the conventional repeats. We do an index, we make the index, and then the index is ready, and then we recall the patient. So same like the previously, videography before the test drive is done. And after that, the patient is put on the chair. The index is loaded with the resin, and that is transferred into the patient's mouth. And then after that is done, another 10 to 12 seconds of post-test drive video is taken. These videos are compiled and presented to the patient. All right. So the initial one, what I showed you was the conventional way with PowerPoints. This is an exocad way of designing this. Coming to raising the bar further, we have a CIREC way of doing DSD. Now, CIREC softwares can be used. This is a single appointment, and DSD can be completed in 10 minutes. And the patients are usually mesmerized with this digital workflow, because they get to see the whole procedure of how their smiles are changing. And I mean, I have personally seen patients don't even request for a test drive, and they agree for the treatment, and immediately we mill the temporaries or the permanents. And patients usually are walking out with the processes within less than 60 minutes, right? So let's see how the CIREC workflow happens. This is a very truly digital workflow. Let us remember that we were talking about digital dentistry. Now CIREC is considered as the as an AI dentistry, right? It's a digital DSD done with an AI technique. So there's an ecosystem of CIREC, where we scan and we design and we mill. So how do we do here? We take the patient's photographs. So we have a JPEG with us, and this photograph is being fed to the CIREC software. And from the CIREC software, the rest of the DSD workflow continues. This is an AI-generated DSD. Extremely precise functional analysis is also being seen here. And truly, to say this is what we create called as an experience dentistry, right? So how do we do this? The interpupillary lines are marked here, the canvas are marked here, the Michelin heights are marked here. Smile window is marked just like the previous. And then we have the AI which is telling us where the midline has to be there. We have the AI telling us where the dental midline has to be there, facial midline has to be there. We try to see different types of shapes and sizes of the teeth. Functional analysis also done immediately. We really don't need a test drive in this. So this is how another way of raising the bar of doing the DSD in a CIREC way. I mean, you can do a conventional way, you can do an exocad way, you can use a DSD apps to do it, or you can take support of the lab support to do a digital way with the 3D printing, or you can go with the CIREC way. And once the CIREC is being done, the experience with the patient experience is much better in a CIREC way. And they usually get really motivated and educated to do the treatments, and that becomes a much better workflow here. Um, I mean, before I conclude, I would still say that there are a lot of parameters which we had seen, a lot of lines on the face, a lot of lines on the teeth. It is just a guideline. Let us not stick to it as a hard and fast rule that we need to get every parameter right. Let's also remember that aesthetic dentistry is, and we cannot get everything right, right? So let us make smile beautiful, if not really perfect, right? So to conclude this, I would say that smile design is mainly subjective. Customizing a smile design is an artistic skill, and we need to practice to see beauty and create beauty. It's always better to be a facial analyzer and create smiles that are in harmony with the face. Shape, texture, 3D position. These are the key points. Shape, texture, 3D position with the face is the key components for the best smile design. Doctors, my friends, colleagues, it was an honor to present my perspective here today. It was a pleasure to have you with us. This concludes the webinar. Thank you for attending. We hope you've learned and enjoyed this presentation.